I hope you find this entertaining. I'm going to try to do something a little bit different than a traditional review, but I'm going to try to give a perspective or maybe perhaps just a bias, but we'll see how you feel about this. So I think most of what I'm going to speak about is really reflected in these next two slides. And something that we don't always appreciate is that things that change over time with regard to oxygen delivery are really dependent on blood flow to an organ or the cardiac output for the whole animal and oxygen content. And we tend to focus a lot on hematocrit levels, hemoglobin levels to make decisions. And what's clear is that as the hematocrit falls, that you're reducing the quantity of oxygen, the oxygen content, maximal delivery. And as the hematocrit falls, we don't become lactic acidotic until we reach what is otherwise known as a critical O2 point, because if we keep reducing the hematocrit, just healthy growing patients, and they're very anemic, eventually extraction has to come into play to take care of the amount of oxygen being delivered. And when you eclipse peripheral blood flow changes, cardiac output changes, so flow, and you eclipse, by becoming anemic, the ability to deliver oxygen and extract more, well then you hit this critical O2 point, and that critical O2 point is when you become lactic acidotic. Now it could be the whole animal, the whole body, or it could be a maldistribution of blood flow, which is an important next concept. Now what we did some years ago was looking at distribution of blood flow by using a tissue pH electrode. So I had developed this microelectrode. You put it subcutaneous. We used the calf, the lower extremities. We did umbilical vein, umbilical artery contents. We measured peripheral blood flow using occlusion plethysmography. And what we found was that there was a metabolic acidosis basically reflected to us as a base deficit, which more often than not, we would just say, well, it's a preterm baby, -6, not so bad. But that meant the pH was adjusted in the blood, 7.35, 7.36, but the tissue pH might be down around 7.0. So it piqued my interest to look at issues of delivery, oxygen delivery, rather than like most neonatologists, we were interested in surfactant and surface chemistry, which when I was in college, that's what I did, surface chemistry. In fact, that's how I got interested in neonatology. But this piqued my interest in distribution of blood flow, oxygen delivery, which we don't seek to describe as often as neonatologists. More so these days with the emphasis on neonatal hemodynamics, and I'll show some data on that. So once again, as anemia progresses, we adjust for that by increasing extraction and increasing blood flow. But what happens when we change the oxygen consumption? When we raise oxygen consumption in dash line, by using vasopressors, dopamine, dobutamine, by having the patient get too cold or too warm, by septic shock when their metabolic rate is increased, by using thyroid hormone, which raises metabolic rate. In any case, when you raise the oxygen consumption, what you do is shift that critical O2 point, and when you shift that critical O2 point, you may shift it to a place where perhaps hematocrits at 28 no longer are sufficient to maintain oxygen delivery, because at that stage, you've already hit that point where if anything happens, baby has a few apneic events. Baby has, you raise the enteral feeding volume, you raise the caloric density, and I'll come back to that concept because the gut has a very interesting dynamic, and about 70% of its oxygen consumption is on digestion. So by worsening anemia or changes in metabolic rate, you can change that critical O2 point where you can't compensate anymore. Once you can't compensate, you have anaerobic metabolism, insufficient delivery, you result in organ dysfunction or whole animal dysfunction. So why don't I change the question somewhat and make it into how and when do stable human neonates, low birth weight, below 1,000, below 28 weeks, when do they respond to anemia? So I'm not talking about septic shock, I'm not talking about toxic medications, heart failure, PDAs, fluid overload. I'm just talking about a growing, healthy, premature baby, 4 or 5 weeks after birth, maybe on full feedings, cannulas, 3 or 4 centimeters of CPAP, that kind of a thing, where it's just anemia. Well, in a very nice paper by Alcalay in 2003, what they did was look at left ventricular output, and they looked at different hematocrit levels and ranges, and they did clusters of babies. And what you can see from the slide here is that when you get below about 26, the cardiac output, left ventricular output, starts to increase. And what they also showed when they looked at blood pressure, heart rate, and a change in hematocrit, a huge change in hematocrit from about 20 up to 30, about 10 points, which would be typical for a 15 per kilo packed cell transfusion, they saw an increase in blood pressure, but really no change in heart rate. In fact, in the next two groups, there was neither a change in blood pressure or heart rate, so that the lowest, the most anemic subset of patients seemed to be most affected. So there was a threshold by which the animal, the human animal, began to respond by changing cardiac output and peripheral vascular resistance as well. So what we see is that at that low hematocrit, that's when cardiac output began to rise, mean blood pressure started to fall, peripheral resistance came down, and so the healthy response of an anemic patient would be to maximize blood flow, to maintain oxygen delivery, to maintain metabolic rate. So those are all stable patients. None of them were shocking. So what do we do in the ICU? Well, you can't do continuous echocardiography, so that doesn't fall away. We have a device called an icon monitor, which measures aortic blood flow by basically an area under the curve of a pressure wave in the aorta, but it's still systemic flow. And commonly, we use continuous monitoring devices like mean aortic blood pressure, systolic blood pressure. I don't know if you can read the graphs. The upper left is the mean aortic blood pressure, lower left systolic blood pressure, upper right is the core peripheral temperature difference from central to peripheral, and the lower right is capillary refill time. And what you can see when SVC on the x-axis was measured, it's pretty much a scattergram. So systemic blood flow might change, as we saw in the previous slide, but how useful is these surrogate markers? Well, not very useful. I mean, if your blood pressure is extremely low, of course, that's an issue, but we're not talking about bleeding patients or hypovolemic patients. We're just talking about simple anemia. So these are not good, continuous monitoring measures are usually not very helpful to inform us about the necessity of a transfusion. So if severe anemia increases, obviously cardiac output is stable in neonates, at what hematocrit does increased extraction kick in? When do we start seeing that neonate having increased extraction? Because we're not routinely measuring flow throughout. So perhaps a surrogate like extraction, not a bedside vital sign, might be helpful. Now the fortunate thing in these days, NIRS is a very useful tool. I've often told the company, I think you named it wrong, because if you said near infrared spectroscopy to most biology type people, physicians, they forgot what that means and you scared them away. If you simply said it's venous O2, might be an oversimplification, but basically what you're measuring is venous O2, so you can calculate arterial venous differences, you can calculate arterial percent, you can get an estimate fractional total extraction is the terminology, where you can get an estimate of how much extraction is coming from the blood. So we started utilizing near signaling. In this paper with John Mincer and myself, 2017, we looked at, let's see if I can use the pointer. Okay. We looked at NIRS in the brain. People call it the kidney, but it's really not. It's the flank. Sorry. It's the flank and the abdomen, just above the umbilicus. And what we found was that if you looked at falling hematocrit on the x-axis and extrapolated that to the 25 zone, which showed you in that first slide with cardiac output, the brain had about 40% fractional extraction, the flank about 50%, and the gut had 60%, plus it had the greatest variability. And that, you might imagine, is not unexpected. It's a moving target, the bowel is moving, there's stool, there's air, so the signal might be highly variable, but so the extrapolation might not be precise. However, you'll see later on when I show some original data on a research, a randomized trial, these numbers are exactly what we got. Not in this picture, the extrapolation, but we actually did the measurements at a crit of 25. So how should we define the need for transfusion? Should it be an adverse effect of anemia? Should it be the patient's response to anemia? They change their cardiac output, so that's a time to do it? Or should we anticipate risks of a new event? If somebody was apneic on top of being anemic, well, that's the patient I should treat. And how do I know where that critical O2 point? When we did the study with tissue pH, we found in the sickest babies that you could hardly define that point. They just kept using the oxygen consumption change with events, but fresh frozen plasma, as we heard yesterday, there was some discussion, or saline, didn't do anything to oxygen delivery, only replacing red cell mass. So I like to conveniently say red cell mass because that is representative of total capacity to deliver oxygen rather than anemia. In any case, I can't easily detect the critical O2 point, And so whole animal signals like cardiac output may be problematic, but is there something we can do with organ-specific, as I showed in the NEARS data? And then overall, perhaps what we're asking is not what threshold I should transfuse, but what's the likelihood that whatever's going to happen in the next 2 weeks is going to tip this patient over that critical O2 point, and then it becomes a crisis. So I don't have any problem now. The house isn't burning down. Why did I buy fire extinguishers? Well, you have them just in case something goes wrong. So what reserve capacity of red cell mass do we seek to make sure that those few apneic episodes don't create a havoc? Now, in this particular paper, this is the peanut trial, which has been mentioned at this meeting before, and it's a second paper that came out in JAMA looking at transfusions and looking at hematocrits. And in this publication, what we showed was that left to right, top to bottom, 24 weeks, 25, 26, and 27, and this was the lowest hematocrit on that day. Now, I think this is one of the problems when people do transfusion studies. What they're looking at is the average hematocrit. They're looking at thresholds of transfusion. In this particular trial, there was a huge amount of EPO given here. This was the schedule, but the transfusion practices were defined by the local hospital. And as you can see, there are very few patients in this 25 zone compared to the upper zones, and that accounts for, in fact, everywhere. So while on the one hand we say we're going to do something, the average hematocrit for each of these patients was either 30 to 36 in that range throughout the first 42 days after birth. So none of these kids were anemic, in my opinion. None of them were anemic enough to cause a change in outcome. And indeed, in this very well executed trial, very well performed, there was absolutely nothing different neurologically or with things like NEC between these two groups. And it was a bit of a disappointment, but in some ways a bit of a reassurance that some things, other than one less transfusion in the first month, had not changed here based upon hematocrits between 30 and 36. Now, I was talking to Wally Carlo a few minutes ago, and we were talking about, how life has gone on. And when I was a junior faculty in the 80s, transfusions were simple. If you were in oxygen, you got transfused at 40. If you were not in oxygen, you got transfused at 30. So the issue of anemia in the 20s never had come up. In fact, we never saw things like transfusion-associated gut injury. And the reason we kind of drifted into lower hematocrits was we were afraid of HIV, we were afraid of hepatitis, we were afraid of transmission of some sort of problem. And why were we transfusing in the first place? As we drifted down into the low 20s, we got into more trouble. And I'm going to show you some data about that now. So what we're concerned about is that if we're going to ask the question, at what threshold should I transfuse? I don't want to wait till you're lactic acidotic or acidotic in general. I don't want to wait till you're failing. Is there an organ I can use as a canary in the coal mine kind of a thing? Tell me something that I'm approaching a problem. And we decided that the intestine was most likely to satisfy the criteria I've listed here as sensitive to effects of anemia, easy to observe and easy to measure the organ's function. There's relevant clinical correlates, nutrition, eating, balance. Is the organ sensitive to changes in delivery? And again, can I measure it? And we saw that in that anemic paper with the NEARS signal. And is it a scalable and measurable observation? So if I'm using NEARS, it's certainly scalable, and I can certainly measure NEARS and average it over time. So one of the things we had done was we noticed there's an association with necrotizing enterocolitis after a transfusion. It was very peculiar in that the baby was about to go home, the hematocrit was 23. I just remember this particular case in particular. Transfused the baby that night. A fellow elected to do it on their own that night, even though we had already decided we're not transfusing. Make a longer story short, it was, of course, a Jehovah's Witness. So although we're sending him home tomorrow the baby got NEC, perforated, and died. So it was wholly unexpected, and I said, how could we be so unclear about criteria for discharge? So there's something else. So then we started examining, going back and looking at transfusions to see if there's any pattern. What we found, and this is Seminars in Perinatology I edited, but we published the paper in, first one in 2006, and American Journal of Perinatology, showing that there was a temporal association between giving the transfusion and NEC only in babies who are also anemic. Now this created a bit of a storm of interest. 10 years later, a very nice paper by Ravi Patel showed that severe anemia, and using a statistical modeling, some of which I would debate if you look at the raw data, but nevertheless, severe anemia, not red cell transfusion, increased the risk that was associated with the risk of NEC. And as I pointed out already in the peanut trial, hematocrits in the 30 on average, or 36, there was no association of NEC, transfusion, no transfusion, it just wasn't there. So I think Rashana Singh is here also. This is a paper she published looking at, on the x-axis, falling hematocrit, and on the y-axis, the probability of getting necrotizing enterocolitis. And as you see, when you get below 30, and I put in the red lines, around a hematocrit of 25 on here, you started getting an increased risk of probability of getting NEC, and then what they also did was look at propensity scoring and whether transfusion, in addition to the NEC, increased the risk of transfusion in addition to anemia increased the risk of NEC, and indeed there was an 8-fold increase in risk. So I found this to be a rather compelling concern that the relationship between something about transfusion, something about being extremely anemic was interacting. So there was a second problem. And if you look at, again, what happens around crits of 25, we saw that cardiac output goes up. I keep going to the right here because I was told I have to move my pointer to the right. So you can't see it, can you? Well, anyway, so cardiac output goes up, oxygen extraction goes up, as we saw. Erythropoietin, if you look at just the blood levels, they start to increase in the low 20s. And something called hypoxic vasodilation from nitric oxide being released from hemoglobin. For those of you who aren't familiar, hemoglobin, in addition to carrying nitric that you inhale, carries nitric oxide bound to hemoglobin, S-nitrosyl hemoglobin. And under low oxygen conditions, it hemocatalyzes and releases the nitric oxide as the chemical local mediator of microcirculation. So what we postulated was that extreme anemia increases the risk of NEC after the transfusion. Now, this was an article that had nothing to do with NEC per se, other than the way they were categorized, but Sood, what she did was look at NERs in the brain and in patients that were transfused, and see from my pointer, okay, good. So what you can see here is she looked at patients before transfusion, right, they were stable, NERs, and she looked at several categories after transfusion. So after you transfused, fractional extraction goes down, so you improved oxygen delivery, so extraction got smaller, that's a healthy response. And what she showed that in patients who did not have NEC, the CNS NERs, fractional extraction, came down, got better. In patients who had NEC a week before, fractional extraction got better. And in patients who got NEC in the week after, oxygen extraction got better. So that there seemed to be no relationship to the transfusion or concerns about blood flow to the brain. So in this case, fractional extraction was improved under all conditions in the brain. However, they also looked at the abdominal area, so just above the umbilicus with NERs, and what they saw that the two groups before or after before NEC and also no NEC, the extraction came down, which you can see in the red and the blue, but in the group that went on to get NEC, in the hours after the transfusion on the x-axis here, these are hours marked in 2, 4, 6, 8, 10. In the hours after transfusion, the fractional extraction got worse. So that suggested that there is indeed an interaction on blood flow, specifically to the intestine, but not to other areas like the brain. Now, around that time, when I edited the seminars in perinatology, I have this figure in there. It's really a conglomeration of some ideas from a variety of investigators, but we hypothesized that like the trolley literature in adult medicine, the transfusion-related lung injury, they postulate that there's a 2-point or a chronic inflammation. Some event happens earlier. And in our case, if a baby's born by neonatologist case, C-section, given formula, they get colonized with gram-negative bacteria, LPSs are released, et cetera, some risk factors. They also have some biological risk factors where they're reduced sensing of bacteria, so they don't have the same flora as the rest of us. There's an increase in TLR4 expression in in general, and this increases the risk of intraepithelial cell decreased migration, decreased division, and apoptosis. So that would tend to injure the villus and create a problem for that patient if these factors existed. And indeed, when we looked at things that lower the risk of NEC, of vaginal birth, mom's commensal flora, breast milk, each of them interferes with the conversion from TH1, TH2, so you get a less inflammatory gut response by those factors. So in a very elegant paper by Akil, wave to the audience. He really kind of integrated this study in an animal model where what he showed was that an anemic intestine was infiltrated by inflammatory macrophages just by being anemic. Second, red cell transfusions activated toll-like receptors and caused bowel injury. Third, the intestinal injury was worse with increasing severity and the duration of anemia. So both the Patel paper and the Singh paper and the argument that we were making kind of made sense in that the anemia itself creates this increased level of inflammation in the gut that was just exposed to bacteria, et cetera, and that on top of that, there's some factors from the transfusion itself and or anemia that change things. So we postulated that, like Trolley in the adult, you had a two-hit hypothesis. The baby had to have an event, infection, hypoxia, ischemia. Then that results in, as in multi-organ failure, systemic inflammatory response syndrome, and endothelial cell activation, inflammation. That releases chemokines and cytokines and increases adhesion molecules, and that the second hit, the transfusion, is incidental. So that, in other words, in the first category, less likely to have, as in the Singh paper. In the second category, the transfusion itself added to the problem. And so here, there are many things in the transfusate that create some issues, among which are a depletion of nitric oxide, and you were originally transfusion on a presumption of hypoxia. So we postulated that the elephant in the room was really the combination of effects, and that the intestine was unique in that its flow was different. Distribution of blood flows, we've learned in medical school, is different than, let's say, the brain, which has an autoregulatory plateau, which basically is maintained almost as an exception under all circumstances. So what does the gut blood flow look like? Well, the muscularis layer has large piercing, I should say, small and mesenteric arteries. The submucosa has additional branching. The mucosa and the villi each have one capillary per villus. And the tip of those capillaries in anaerobic intestines, the tip of those capillaries have PO2s below 20, and depends on who you read, but as low as 10 or 15. So we would never have a fetus, we never have a human, not to mention even a fetus, where the PO2 is 25, this low. But normally, our villus is maintained at that level. And what happens is, this villus is very metabolically active in secretion and resorption, and 70% of oxygen consumption in the intestine is related to the process of digestion and absorption, as opposed to gut motility. The musculature is only about 30%. So that's an important insight, I think, as well, when we change our feeding volume, when we change the content of the feeding, 20 to 24 calories, we're changing the metabolic rate of the gut. So then we said that's one possibility, but what about those red cells? What about storage? We really intuitively know a lot about it. In practice, we just tend to give the transfusion. Well, physical structure changes when red cells are stored. They tend to make rouleau effects. They stack up in long, like a stack of coins. There's a number of things that are more easily fragmented. There are metabolic alterations. Everyone knows about 2,3-DPG, but among other metabolic alterations is a drop in ATP and higher potassium, higher lactate in the serum. In the diluent, if they're in saline or serum. Nitric oxide is not bound any longer to the hemoglobin. In fact, the hemoglobin you're infusing in the red cells has 0 nitric oxide, and since red cells in storage increase the likelihood of fragmentation and free hemoglobin, when you infuse free hemoglobin, and I suspect when you were a medical student, you said, well, why don't you just give hemoglobin? Why do we need to give red cells? Well, free hemoglobin causes a vasoconstriction that in humans has been shown to be nitric oxide dependent. And then last, and probably not easy to measure, perhaps not necessarily directly contributing, is as you store cells, you activate white cells, you activate platelets, you release cytokines, and they're all active, and even things like T antigen at the very bottom. So when we were thinking about, I give transfusions the first week, the second week, the third week, but this gut injury transfusions issue was growing premature babies, less than 1,000 grams, 4 weeks or more after birth, full enteral feedings, low oxygen cannulas, something like that. The only thing that in this list that existed as an issue, or remained as an issue, late was the combination of decreased nitric oxide in the transfused blood and the fact that the intestine is dependent on it, and I'm increasing feedings, I'm increasing caloric density. So we reasoned that maybe if we treated those babies with nitric oxide beforehand, that hypoxic vasodilation might exist, and if you didn't, then you would actually cause vasoconstriction. So we designed this clinical trial. It looks more complicated than it is, but basically they were being fed, if they're over 4 weeks, I'll show you that data, then we make them NPO, we give them nitric oxide, we transfused over 3 hours, then we observed them without being fed for another 2 hours, but continued the nitric oxide, stopped that, and then continued to be NPO until the next day, basically 12 hours later. And then during that period, we had given them inhaled nitric 20 parts per million by cannula. Most of these kids were on cannulas or NYMV. You'll see that in a moment. Now, it's a busy slide, and I know it's a half-an-hour talk, so I'm not going to go through this in each detail, but if you follow along on the right column, and if you glance back and forth, what you'll see is that these were all 25-week gestational babies, and they were about 5 weeks postnatal age when we studied them. They were gaining weight, 14 grams per kilo per day at 35 days after birth. Their head was growing normally. 50% of the subjects were in more than 30% oxygen. So although I say growing healthy prematures, you know, as an intensivist, they look pretty good to me. They're not on ventilators, they're not on an oscillator, that sort of thing. So they're just 30% oxygen. 70% were indeed on cycled, which by that I mean not NIMV. They were all, 100% were on therapeutic caffeine levels, and we tend to keep them above 20. 95% were on full enteral feedings, and 70% were on continuous infusion. So even making a baby NPO during a continuous infusion, well, what happened to the nutrient that was in the intestine the last 4 hours? Well, it's still moving along. So conceptually, maybe, and some practices have done this, they make babies NPO for longer periods of time. But these are children who have no IV, and they're just growing. It seems a bit much to put a second IV in to keep the glucose the same during their transfusion. So there's an issue. 100% of our babies are on breast milk in this weight group, and all of them are on 24 or 27, depending on the baby. So they were pretty good shape overall. What we saw was a 10-point increase in hematocrit, 15 per kilo. The average hematocrit went from 25 to 35. There was no change in the platelet count. Before, it was normal in the 300s, and after. In this case, lactate barely changed. There was no significant change. It's barely measurable. It just averaged out. And there was no change in blood pH. In addition, when we looked at the nitric group on the top here, 26 patients and 24 in the, these were blinded tanks that the company had given us so that it said 20 parts per million whether you got nitric or nitrogen. So in the nitric oxide group and in the nitrogen group, absolutely nothing happened with heart rate, blood pressure, mean aortic blood pressure, SpO2, and so in essence, we didn't detect any significant change in biology. Now, that was very different when we looked at the NIRS. This is a complicated slide. I'm going to take pieces of it and show you. So like everyone else who's ever done this, if you looked at NIRS in the abdomen, in the flank, can you see my pointer there? Okay. If we looked at the abdomen, flank in green and CNS in red, there was an increase after transfusion where the flank increased the most, the abdomen increased second, and the brain, as might be expected, autoregulation changed the least. During transfusion, in green here, that was the increase. Now you'll notice that in the brain and the flank, the near signal, in this case not FTOE, but I can show that at the end if there's time, the near signal stayed up throughout the next 15 hours. In contrast, in the gut, there was an increase, as we saw in the previous slide from SUD, and then it started to fall and drop down to baseline 10 hours after we started the transfusion ended. And about let's see, it's about 14 hours after the, 10 hours after the transfusion ended, leave it at that. And the nitric oxide a little bit shorter, stopped here. The following day, when we restarted feedings, we noted that there was no change in the near signal when we reinstituted feedings at half the previous volume. Now, when we looked at the same data from the babies who were given nitrogen, blinded, there were 24 of those patients, and again, the gut was the lowest near signal, only at 40%, which is rather low for the intestine. The flank was 50%, and the brain was 60%, which is incredibly low for the brain at a hematocrit of 25 in stable growing neonates. And in each of them, the quantity of increase was the same. However, in this case, if you look at the arrow, the transfusion had no effect on the, it's a trick to get this to work, the arrow. Okay, so that the transfusion increased the near signal in all areas. The brain and flank stayed the same out to 16 hours, whereas the gut increased transiently and fell quickly. And you can see by the length of the arrow that after nitric oxide was stopped, it was half the time that the signal was elevated. So we concluded that nitric oxide during transfusions for extreme anemia sustained only gut mucosal oxygen delivery until it was stopped. So in summary, what I'm showing you is that tissue oxygenation was abnormally low in all sites during extreme anemia. That tissue oxygenation was lowest in the splanchnic region compared to the brain or the flank when the hematocrit averaged at 25. At least I would consider that to be extremely anemic. We can debate the threshold issue, of course, but 30 and 36 was never a problem throughout my career, so this to me meant this is a significant change as we were seeing throughout. Packed cells initially raised tissue oxygen, flank greater than the abdomen, greater than the brain region. Nitric oxide sustained regional oxygenation at the splanchnic site twice as long, but had no effect on either the brain or the flank. Fractional extraction, and if we have time, I can show you. Basically, it's a mirror image of what you see with the NIRS. FTOE worsened in the splanchnic region only after the nitric oxide wore off. And distribution of blood flow is subject to many whole animal and organ-dependent control mechanisms. In the case of the intestine, I can measure function, I can measure NIRS. I know that I increased the caloric density, that the metabolic rate's going to go up. So what would we speculate on this? I know selectively affects the splanchnic microvasculature in packed cells, and I think that's really an interesting demonstration of biology. People have measured this in animals in the late 1990s. They showed the exact same effect in rats, mice, dogs, and cats. And in humans, studies have done that showing this esternitrile hemoglobin is the release of nitric oxide in capillary beds is the local vasodilator. So it's not really new, but it's new in the sense that it was first time we can show a nitric oxide effect in babies, living babies in the ICU. We speculate that nitric oxide during transfusions may reduce the risk of transfusion gut injury, and that is NEC. And what we seek to do is a properly powered trial. This was supposed to be a pilot investigation that it took several years to get it done because of the very restricted criteria, less than 1,000 grams, more than 2 weeks, no PDA, no sepsis, growing preemie, not on an intubated ventilator, could be an oxygen or cycled, had to be hematocrit below 28, and most of them were not reticking, which was also of interest. Now, let's just get back to the last slide, the original question. So he said, Ed, what would you do today if you were on service, which I was last week, and how would I manage that patient? Well, basically, we're pediatricians. We give vaccines because we want to avoid the problem. I don't want to have a negotiation about what the threshold is. I just don't want to have the problem. So one way to deal with that is to regress back to what I used to do in the 80s, and like everyone else, I want to keep the hematocrit above 30. Well, in this case, I would concede 28 seems like a good number in this era. So I propose that if you really don't want to deal with this discussion, one way or the other, if your hematocrit's above 28, you don't have a problem. The multiple papers have shown that. The Sunny Jewel one is just one that I'm particularly fond of because we were part of it, but it was just so clearly, so well done. There was no effect of transfusions, whether your crit was averaging 30 or 30 or above 30. And then what would I like to do? I'd like to do that randomized trial where we examine the combined risks of transfusion and anemia. It became increasingly difficult because these days everyone uses the EPO when they, at least in our service, begins to use it when the baby becomes anemic, below 28, and the retics are not increasing. And I had a fellow that just started in July, and I think she's fantastic because she told me, I said, what kind of research are you interested in? I said, in September. And she says she wants to look at EPO. And I said, EPO? Everybody's done EPO. There's nothing new in EPO. She says, well, you have no coherent policy for using EPO or stopping it. And I said, you know, you're right. So we're going to develop a clinical trial on EPO randomized into kids who are not reticking and decide whether it does make a difference or not. So I thank you for your time and attention. I'd be happy to answer any questions.